Hello, everyone. Welcome to today's webinar, Reinforcing the Safety Net, Ensuring the Future of the 340B program. I want to start by thanking our friends at Grantmakers in Health, Grantmakers in Health for partnering with us in this initiative and all of our speakers. I'm going to ask Sarah to share the agenda for today's call. So this is what we'll be doing today. Just so you have your expectations set right for today's call will be 1 hour. So think of your questions, be sure to share them in the Q&A. We also have some logistics to share. Because there are so many of you on this call, all attendees will be on mute. The session will be recorded and will be available on our website subsequently. As I mentioned before, you can offer comments through the Q&A function or through the chat. I'm now going to turn the floor over to my colleague, Anne from Grantmakers in Health.
Thank you so much, John. I'm Anne McMillan from Grantmakers in Health, and we're so pleased to be able to co-sponsor this webinar today. For those of you who don't know, Grantmakers in Health is a professional association for health philanthropy. We conduct educational programs and networking events and leadership development opportunities for the staff and trustees of foundations and corporate giving programs. So I lead our work on access and quality, and I can definitely confirm how important this topic is to the funding partners that we work with, whether it be vulnerable populations, in rural areas, or there's so many community health centers that our funders support across the country. This is a critical issue. So I have the pleasure to introduce Jeffrey Lewis, the president and CEO of Legacy Health Foundation, with deep expertise in health and philanthropy and this topic. I'm so pleased to turn the call over to him as our moderator today.
Thank you, Anne. Wonderful to be here, and thank everyone for joining us. The 340B program began as a small but highly effective component of our nation's safety net. Since its inception in 1992, the 340B program has seen incredible growth. But while we've seen growth, we've also seen damage caused by hospitals and health systems who are pilfering the program for profit with little accountability. While other safety net providers like federally qualified health centers, Ryan White clinics, STD clinics, continue to serve the nation's most vulnerable and day after day meet the regulatory and transparency requirements that nonprofit hospitals and health systems don't face. The result, pharmaceutical manufacturers have started penalizing safety net providers as hospitals and nonprofit systems continue to expand 340B revenue. The irony here is that while pharma companies argue that the explosion of contract pharmacies is one culprit, there appears to be a lack of understanding about access. Contract pharmacies were created to help ensure that patients have ease of access to needed medications. Pharma may not understand that not every covered entity can afford to have its own in-house pharmacy. This morning, I'm joined by 4 amazing experts to discuss the challenges and the opportunities in the 340B space, particularly those living with HIV and AIDS. Let me introduce our panelists in alphabetical order. Bill Keaton is the Vice President and Chief Advocacy Officer for Vivian Health. Vivian is a nationally recognized leader in the fight against HIV/AIDS and operates the only HIV medical home in America recognized by CMS. Basharia Keys is the Director of Regulatory Affairs at the National Association of Community Health Centers, also known as NAC. Mary Elizabeth Marr, nicknamed Mimar, in case you hear me use that name, is the President and CEO of Thrive, the premier provider of inclusive, high quality, and affordable health care in Alabama. And last but not least by any means, Jesse Milan is the President and CEO of AIDS United. So with those introductions, let me turn to Basharia with the first question. And let me just ask before we get into some questions, how about giving the audience a little bit of background on 340B, given your expertise and NAC's most important role in that space?
Yeah, thank you so much for the question, and thank you for having me here today. So we are actually coming up on the 340B program's 30th birthday in November. So for the last 30 years, the 340B program has helped safety net providers like health centers, Ryan White clinics, Title 10 clinics, and even some hospitals as well, have access to discounted outpatient medications. And so in 1992, when this program was created, it was kind of a building block upon a Medicaid rebate drug program, which allowed Medicaid agencies to purchase discounted drugs to help the populations they serve. And so this was kind of an expansion of that idea, but to provide an upfront discount for safety net providers to purchase those medications to be able to help really the underinsured or uninsured patients have discounted medication, but then also to provide extra revenue or 340B savings to those safety net providers so they can expand the types of services they provide to the same exact patient population. So everyone's favorite phrase to quote about why the 340B program was started was to stretch scarce federal resources to really provide those discounted services or expand those comprehensive services provided by those safety net providers. And so part of kind of when we get into the contract pharmacy issue is that manufacturers are required when they sign their agreement to work with Medicaid and Medicare Part B, they are required to provide these discounts to 340B covered entities or safety net providers. So there is a contractual obligation that manufacturers, if they want to provide medications to Medicaid and also Medicare patients, they have to participate in this 340B program. And this contractual arrangement is kind of where this tension is arising, where the manufacturers aren't really holding up their part of the bargain, but we are still kind of stuck in this cyclical effect of who's doing what and who's required to do something. And so why the 340B program also is so important is that at its inception, safety net providers who really started off in the 340B program, in 1992, at that point did not have in-house pharmacies, what you said. So Congress started this program with the intention that they knew some of these safety net providers were going to have to contract with local pharmacies, family-owned pharmacies, as well as bigger pharmacies like a CVS or Walgreens to be able to provide those services to their patients as well. And so how the 340B program kind of works, because I think this might be helpful context, is so a covered entity purchases, an outpatient drug at the 340B price, which is lower than what they would pay if they were just, a normal provider or health system. So they purchase this discounted medication, and then they're reimbursed by a health insurer at the full price. So then that in-between spread of the 340B price and the actual retail price, the covered entity gets to keep those savings. But the difference between a grantee, specifically like a health center or a Ryan White clinic, and a hospital is that, a health center or a Ryan White federal grantee is required to reinvest those savings back into the 340B program. So not only do they use those savings to provide discounts to underinsured or uninsured patients, but then that money gets put back into patient care. And I'm sure Mimar and others will talk about what those services look like. But it really goes to the care that doesn't generate revenue, but is so critical to serving our patients and getting them in the door. So transportation services, food security, also community health workers who can spend the time to help our patients navigate the health system or to understand their needs so that they can work with the provider better to really, have the continuum care that they need. So not only is it about affordable medication, but also the idea that those same vulnerable patient populations deserve to have access to comprehensive care, respectable care, especially when we talk about, the focus of today, which is HIV and AIDS patients, that respectable care close to them. And so, 340B, and I might be getting ahead of the talking points, but 340B is like a multi-layer program that has multiple issues or multiple ways it could be improved. And so I think we're in this period now where some of the issues are really stemming from the fact that the program hasn't been revisited since 2010. So in 2010, there was another kind of expansion to 340B, which allowed other hospitals to join and be eligible to be a covered entity. But then also in 2010, it expanded the use of contract pharmacies, and it specifically allowed allow covered entities to have multiple contract pharmacies. So when manufacturers talk about the 340B program and how explosive it is, they really do start kind of at that 2010 mark, because that's when more hospitals joined the program. And then also there were more flexibilities around allowing more contract pharmacy use as well. But if you look at it, we're talking about a program that's grown in 30 years, but we're still operating off of the same regulations and rules from 1992. So it's not a coincidence that at this point in 2022, the program is not working the way it is supposed to. And it's time for, to revisit the structure of the 340B program. As, I think we all can admit we're different people 30 years down the line. So why wouldn't the program be different 30 years later?
Last week, I was reading an article about the 16th pharma company that decided to restrict its contract pharmacy program. Can you share with the audience why 16 pharma companies are taking this approach?
Yeah, so I'm still trying to figure out why manufacturers decided to restrict access to contract pharmacies in the middle of a pandemic. But I will give my best to kind of shed some light on it. So there's multiple viewpoints on contract pharmacies. From the covered entities, so the health center perspective and the safety net provider perspective, more contract pharmacies increases access for our patients. The vulnerable patients that we serve have multiple barriers in between them and accessing their care, or just things that they need to have a quality of life. And so for you to want to pick up your medication, from the health center perspective, the safety net perspective, we don't want there to be another barrier that you have to face because you want to pick up your medication at a pharmacy that's familiar to you, maybe next to your child's daycare, maybe next to your job, and you should be able to do that and then also still receive those discounts that you are entitled to because you went to a safety net provider and they wrote you a specific prescription that allows you to have access to these discounts. So for us, it's increasing access and making one thing easier for our patients. From the manufacturer,
for a second, and really raise an important point. Is this an effort by pharma to reduce the role of what hospitals and health systems are doing in a 340B space at the peril of STD clinics, Ryan White clinics, and FQHCs?
Yeah, it definitely is, because for them, they see only dollar signs. And for us, we see the patient and what is good for our patients. And they just want to talk about money and we just want to talk about access. And so we're having two different conversations.
And I think we're going to have one conversation today. So let me turn to Mary Elizabeth Marr, who's the CEO of Thrive Alabama, operating in multiple sites across the state, where 340B revenue is sort of critical to your success. You can give the history on why you became an FQHC, because no one will do it better than you, because the passion in your voice is just extraordinary. So let me just start there and we'll dive in.
Okay, I'm going to talk very quickly because I've got a lot to say. First, I really want to thank everyone who's on this call. As I look down the list, I've received funding from many of these organizations. I try really, really hard to look under every rock for funding to take care of my patients. So I came to Thrive Alabama in 1995 as a board member, and I've been here ever since. So when we started out as a Ryan White clinic, and we had, and when I started, 198 clients. I have over 1,000 clients today, but we've not received any extra money for taking care of all these people. So I had to go out there and try to figure out how was I going to continue to provide services and the services that my clients desperately needed. So the first 340B was obviously my Ryan White. I've been in the program for almost 15 years. Then I was seeing that we needed PrEP And we needed PrEP for those patients who were not HIV positive, but we wanted to keep them HIV negative. So PrEP was wonderful, but lots of people don't have resources. So I became an STD clinic. And by doing that, I went to the state health department. I said, hey, I want to become an STD clinic. It's usually just the health department in Alabama, but I want to do it. And they agreed with me and they allowed me to become an STD clinic. So therefore, I had money to take care of my PrEP patients. And it's not just the laboratory services. It is the physician, the nurse, the receptionist, the MA. It's sending out those labs. It's getting people to the resources. It's advertising that we're an STD clinic. It's providing outreach. I could go on and on and on. None of the admin things. Those are all just the medical things. So then what was happening was that I still needed additional money because I wasn't getting any new Ryan White money. And so I became, it's an arduous process to become an FQHC, probably the hardest thing I've ever done, but I jumped into it. And the reason I did was I saw that we could provide the great care that we were providing for non-HIV positive patients that we were providing for our HIV positive patients, our compassion, our comprehensive care. But the other, I had no idea this was going to happen. But by changing our name to Thrive Alabama and starting to see negative patients, we reduced the stigma for our HIV positive patients. Now they were going to the AIDS Action Coalition or even AAC, but everybody knew we were the AIDS clinic. Now no one knows why they're coming to our clinic. We do receive a large amount of 340B income, but I want you to look on this one pager, and this is a one pager that I take to Congress, to anybody who wants to know about 340B. All these services we're now able to pay and provide for our clients, which we could not do without 340B money. The big thing that I really want, okay, I'm sorry, Jeffrey, go ahead. I can't hear you, Jeffrey.
Can you hear me now?
Yes.
Okay. So it's really important to address this issue, that explain to people how you use your 340B revenue to help pay for medications that an uninsured person or an underinsured person can't afford.
We do it in a number of ways. We have as an FQHC, we have a sliding fee scale that is extremely regulated. If you come in and you don't have, we can turn no one away. That's in our charter. As FQHCs, we can turn no one away. So we see homeless people, we see people with insurance, with Medicare, with Medicaid. And the point here is that if you cannot pay at the beginning, you cannot pay for your appointment, we have a mechanism to pay for someone's medical care. The next thing is that if they cannot pay for their medications, we can help them with their copays. Again, using that sliding fee scale. What Vasharia was talking about with all the contract pharmacies, we do that because patients have choice in our program. And we don't have an in-house pharmacy. Maybe someday we will, and they'll have that choice to walk down the hall and get their medication, but they can also get it delivered to their home. They can pick it up from here. They can go to Walgreens. They can go to CVS. They can go to Walmart. They can go where they want to go, which is really important. And again, you can see all these services that we provide with our 340B funds. If we start losing our 340B funds, which it's being chipped away, I'm going to have to make a decision on which services I'm not going to be able to afford to give people anymore. In Alabama, we're a non-expansion state for Medicaid. People do not, 92,000 people in Huntsville, Alabama, do not have adequate health care. And I will turn no one away.
Let me do a follow-up question with you. Are there specific ways the 340B program could be changed to help ensure both greater flexibility in serving more patients, but particularly people who have HIV or AIDS?
Yes, it can be left alone. That's what it can be. I'm sorry. I'm just being completely honest. I do nothing wrong. I had a HRSA audit last summer. We pay for we have a compliance program. We audit our own charts. We have an outside company audit our charts every 6 months. Our program is completely regulated. We are doing nothing wrong. I am putting the money back into my program, which is what the legislation wanted us to do. So with less money, we're going to be able to pay for less services. And that's just not right. To now say to our customers, our patients, I'm sorry, I'm going to have to cut back on transportation. I know you have no other way to get here, but I'm going to have to cut down on that service because I don't have the money.
You know, the irony is
We can't hear you, Jeffrey.
Can you hear me now?
Yes.
Yeah.
I'm sorry. I'll just
Lean in, Jeffrey, lean in.
So ignore the top of my head, you can't see. The sad part is that federally qualified health centers are not only the safety net for millions and millions of Americans, but they are increasingly becoming the safety net for insured Americans. Because as we have more and more doctors who are retiring and there's not a backbench to replace them, that's where they go. Because they go there because of places like Thrive and other NAC members who provide quality care, and they know it and the reputation's out there. So I know that you want to leave the program alone, but Sherry had talked a little bit about it's 30 years later. There's some tweaks we need to make to the program. But let me turn real quick to Jesse to really talk about advocacy and what you've been doing with your organization, Age United, and how do we take advocacy through Age United and blend it with NAC's role in terms of legislation and policy to make sure that we have a 340B program that really does respond to the needs of everybody, but in particular that we don't ignore the population who wants to use a PrEP drug, who wants to use the revenue for other HIV/AIDS services, that today their hands are tied because the law doesn't allow them to do that. Jesse, can you speak to that, please?
Well, thank you, Jeff. And I also want to thank Grantmakers in Health and FCAA for pulling this webinar together. This is a timely topic, not only in about HIV, but it's a timely topic about a number of different diseases. But it's especially helpful coming out of the pandemic, where we've been talking about health equity, because I think Mary Elizabeth, we all call her Mimar, has made clear is that the unreimbursed and the unfunded care or underfunded care that she provides is particularly helping people of color and people who live at the margins, people who do not have who otherwise would fall through the safety net that the services that Thrive Alabama and so many of our members provide. Age United is a national organization focused on ending the HIV epidemic. And we are also a membership organization. Our 56 members of our Public Policy Council, who include Thrive Alabama and Vivint Health, have banded together to help do advocacy through Age United with Congress. But a subset of that group banded together in a collaborative to focus exclusively on the 340B issue. And I appreciate so much their leadership, because particularly over the last 24, 36 months, there's been a sense of an existential threat with regard to Congress starting to look at the 340B legislation, particularly because, as you said, Jeff, some of the abuses that we've seen from the larger healthcare systems, but not from the Ryan White providers, not from the FQHCs. And so it's important that our members help get the story out as to what they're doing and how they are actually providing that safety net service through the 340B revenue that they generate. And so those 13 organizations who are members of our Public Policy Council include some of the most important HIV/AIDS service organizations in the nation. And they include, of course, Thrive Alabama. They include the APLA in Los Angeles, Vivint Health, which Bill Keaton will talk to us about. They include Whitman Walker in DC, Legacy Community Health in Houston, Prison Health in Texas, Equitas in Ohio, Fenway Health in Boston, Howard Brown Health in Chicago, San Francisco AIDS Foundation, and Desert AIDS in Palm Springs, as well as the LA LGBTQ Community Center. They've all come together under the flag of AIDS United and a joint MOU to work together to bring their voice to Congress to share the great story about how they are legitimately using 340B services to provide that great safety net. And frankly, AIDS United works in partnership with other organizations all the time. And we had a great partnership several years ago to help preserve the Affordable Care Act with organizations all across the spectrum of healthcare, including Planned Parenthood. We're certainly standing ready to do that kind of collaboration to help, as Mimar says, preserve the 340B program.
Are there specific tools that your organization can recommend to other nonprofits who are concerned about what's going on in the 340B space that they could use, that you could help them build a campaign that where they may not be part of AIDS United but want to be helpful?
I think Mimar has given a great example through her one-pager. In fact, as we were preparing for this session together, she said, everyone should do this. And I think she's right. Document in as simple a way as possible how you use the 340B program and how that revenue is actually supporting people at the margins who otherwise would be falling through the safety net. And I think we all can look across the spectrum of like organizations, be they in the mental health field, the sexual reproductive health field, in the infectious disease field. All of us have the same issue before us, and that is preserving the opportunity to address in this economy how we remain sustainable to provide the services needed by the people most in need.
Thank you. That's great. I'm going to turn to Bill from Vivian Health, and your organization is a leader among many across the country. The exception in this case is that you have the only CMS certified medical home for HIV/AIDS patients. Can you talk to the audience a little bit about what you did and why that was so important?
Yeah, happy to. Thank you for the question, Jeffrey, and thanks to everyone for being here. It goes back to something that Mimar was talking about a few minutes ago, and that really comes down to, as safety net providers, we have an obligation to look under every rock, every crevice, to find every resource we can to support the care and treatment that is keeping hundreds of thousands of Americans living with HIV alive. The truth of the matter is that the federal government and state and local governments across the country, we're in 4 different states, really have shirked their responsibility in making sure that the safety net is fully funded, whether it be through grant programs or things like Medicaid and Medicare reimbursement rates. The list goes on and on. The dollars just don't add up in terms of what we're able to generate in government revenue to meet the needs of serving the people we care for with the dignity and respect that they need. The CMS designation that we received is a portion of the Affordable Care Act. And what it recognizes is that the model of care that we've built, which is comprehensive integrated care that is meeting not only the health needs of the people we serve, but also some of their social service needs, things like food pantries, housing programs, legal services, case management. Those are all completely integrated with our medical care, our dental care, our pharmacy services, and our mental health services to create one provider network, if you will, to meet all of the different needs that folks from us are presenting with. And it comes with an enhanced reimbursement model, but also some strings attached in terms of demonstration of cost effectiveness and outcomes, which we're happy to report on and make ourselves available to. And that's also why we decided to go the 340B route. We created an in-house pharmacy because, frankly, while I don't want to talk badly of my friends in Walgreens and CVS, but we recognized that the contract pharmacy arrangement was a something that was causing some of the revenue that we could be using to be going into the stock shares and the profits of for-profit industry. And we decided it was important to meet the spirit and the intent of the 340B program to keep as much of that revenue in-house as we could. And I recognize that we're blessed in our ability to do that. Not everyone can. But it really comes back to, Jeffrey, we've got to look everywhere for every resource to meet the growing demands of the people we serve. And whether it's alternate payment methodologies, 340B revenue, and then also the full expectation that Congress really needs to come together and figure out how to fully fund the safety net. The 340B program in many ways was created because Congress recognized it did not have the political will or the financial ability to meet that need, and required some additional enhanced contributions from other players in the industry, if you will, including the pharmaceutical industry and the insurance industry.
So can you speak to the issue of roadblocks? So what are the limitations that you face in the 340B space in using those dollars that if we talked about, we're in an almost 30th anniversary of the program, what kinds of regulatory changes could be used? Not necessarily legislative changes, but what kind of regulatory flexibility would help your program or MEMAR's program in the use of 340B dollars?
Yeah, that's it. That's a great question. And I'm going to try really hard to not get super wonky here. So please interrupt me if I do. To become a 340B entity, an organization must be a recipient of certain federal grants or a designation by the federal government. And what the federal government contends is that when you enter into a 340B covered entity status, any revenue or savings that you generate as a part of your participation in that program must only be used to fund those services that align with the services that are funded with the grant. So for example, as a Ryan White grantee, we are only eligible to use Ryan White funded dollars from the federal government to provide HIV care and treatment services to HIV positive individuals. So we, for example, cannot use 340B savings generated from our participation as a Ryan White grantee to fund prevention services, even though it's very likely that the person who's coming to us in need of testing and PrEP and syringe service programming or whatever happens, that they come to us, that person might live next door and in the same socioeconomic and health conditions as someone living with HIV in their apartment building. We can provide robust services to that individual with HIV. To the person without HIV, we cannot. So when you talk about regulatory sort of changes that could be made, that one may need statutory changes, but it certainly is something that we've really pressed on HRSA, the federal government partner on this program, to really be mindful of, because what it creates is an artificial bifurcation of patient populations based on one disease characteristic.
And if I could just piggyback on that, I think some of the regulatory changes that need to happen is more so to protect covered entities in 340B. There, is very limited recourse of what we can do now with, for instance, the contract pharmacy issue. Legally, a health center cannot sue a manufacturer due to 340B issues. We have to go through the alternative dispute resolution process, which NAC is currently going through for the last year and a half. And manufacturers have used every excuse in the book to slow walk the process because they know we cannot intervene in their lawsuit against HHS. And so, as a covered entity, there's not a lot of regulations about, how you can do it and what you can do it. It's usually your federal grant status, or you as a hospital have just outside regulations that intertwine with the 340B program. But one of the things that NAC is advocating for is who is protecting the covered entities, who is telling, manufacturers, you can and cannot do this. HRSA is trying with the authority that they have, but it's very clear that HRSA has stretched their authority as far as they can, because we are at 16 manufacturers that are refusing to ship drugs to contract pharmacies. And that has happened from the summer of 2020 in the middle of the pandemic to of last week, Johnson & Johnson making 16. So when you look at it, there's not really authority protecting us as covered entities, and we are in a very much take it or leave it approach. You could take these drugs or not. You could give us your data or not. You could take this lower reimbursement or not. And then so what we do is we take what we can get, but there's not actually a regulatory mechanism saying this is the way that covered entities should be treated in this program. And if you don't, these are the repercussions. HRSA is trying as much as they can, but it's very clear that manufacturers are not taking them seriously. And so what are we left with is very little recourse of just operating in a program that is not functioning the way it's supposed to.
Yeah, and if I could add one thing to that, Bashir, that was spot on. And Jeffrey, just to add this, it's not just the pharmaceutical industry that is one of the barriers to the success of the 340B program. Oftentimes, insurance companies, health insurance companies, through pharmacy benefit manager programs and their Pbms, are one of the greatest culprits in literally pilfering money away from the 340B program covered entities to pad their own profits. What happens, and I'm gonna try not to be too wonky, but we buy the medication through the 340B program at this price. As a covered entity, we are trying to get the reimbursement at this price, the standard reimbursement from the insurer. And what the Pbms are saying, oh, you're a covered entity? Instead of reimbursing you here, we're going to reimburse you here. And all of those savings that are supposed to be coming to us are being realized in the insurance industry in the PBM profit P&L sheets, because they're coming in and swiping that out just based on our status as a covered entity. And then furthermore, are requiring that we give them data to help them do their jobs, because one of the reasons why they want to capture that money is because the Pbms have a different relationship with the pharmaceutical industry, by which they are guaranteeing their insurance company holders greater rebates. It does get complicated. It does speak very much to just what a at times disastrous sort of financing mechanism we have for healthcare, especially the healthcare and social safety net in this country. But boy, you know, the attacks are not just coming from pharma; they're coming from every other kind of sphere or player in the sphere of the health industry in this country.
What's the advocacy opportunity to talk about health insurers and PBMs? To Bill's point, when educating both members of Congress, but also decision makers, both at the staff level and at the state level, of what that role that health insurer really is and what the PBM is really doing, and how much money they're making in the 340B space. How do we help educate these elected officials and their staffs? I'll go to Jesse, you first, and then to Nimar.
Really, lesson number one of advocacy is tell your story. CEOs, from CEOs to patients, the listening may be somewhat different as to what they're listening for, but telling the story of the great work that you do and the great impact that might happen should a certain legislative initiative happen is what legislators are listening for, and especially their staff. And once again, I think Mimar has given us a great model. How are you using the funds? How is it being used legally and properly under the existing statute? And what is the impact that it's making? You know, I've been living with HIV myself for nearly 40 years, and I live in a pretty privileged world as a CEO with health insurance and with a pharmacy an hour, you know, a mile and a half from my house that I can drive to. But the impact for the people who I represent is an impact that needs to be understood and heard, because the underserved populations that are being served through these services that Mimar and Bill Keaton have so beautifully described are those that are not merely life-affirming, but they are life-saving for some people. I mean, we're talking the ability to have childcare while you're at a doctor's appointment. We're talking about walking home with a bag of food. And in some instances, it might even mean for people who are vulnerable to HIV, the opportunity to get a clean syringe. Those are the kinds of things that are being funded with this program. And when you say all of that to a Congress member or a staff member, you literally can see the light bulbs go off, that is exactly what they didn't understand, but now they understand it, and they understand it's happening in their district, in their turf. That's the most important way to do advocacy.
So I go to Congress until COVID. I was up in Washington every other month. And I was up there with AIDS United. I was up there with Natch. I was up there with Ryan White, with Ryan White 340B Coalition. I belong to all these coalitions, and I love, this is the part of my job that I love, is to educate about what we're doing. I oftentimes bring a client, and actually I believe that there is even someone on the call who came with me as a client. And so I'm not going to out anybody, but the point is, I want to tell you a real quick little story. So we had a woman who was receiving housing from us, and she talked to her housing case manager, and she said, okay, I'm ready to go out on my own now. And the housing case manager was just shocked. And she said, your help has allowed me to get on my feet, and for me, and I want to make sure that someone else can get my apartment that needs it, because I know you have stretched resources. And not, she didn't use those exact words, but my point is, we got her all the way through from being homeless and on the streets to having a home to go home to that she was paying for. That is life-changing. We also, with the help of, real quick, with the help of AIDS United, we go up in next week. We'll be doing virtual, of course, this year, but we have a program called AIDS Watch that we all participate in, and that we bring clients from as nearly 50 states. I think we're like at 40 something states. And we take them up to Capitol Hill, and we let them tell their stories. We're there just in the background to tell the nitty gritty, but they hear from us. We need them to hear from clients. And as an FQHC, this is also important. As an FQHC, 51% of our board are clients, receivers of service. So I educate my board on a very clear level, and they make calls, they write letters, and one of my board members was going to go to AIDS Watch with me this year to go up to Congress.
Mimar,
go ahead.
I just want to say, Mimar, thank you for that wonderful shout out. AIDS Watch is next week. We already have over 400 people registered to participate in AIDS Watch, and we already have over 120 meetings with Congress happening next week. So we're taking this story. Now, the impact of the story told by a CEO like Mimar might be, this is how I'm serving thousands of people in my community. But the story of a patient, of what it means for them, helps sell it home and make sure that the true heartstring impact, which Congress does care about, is being heard.
And I just want to point out, so the issue is who gets to that congressional member or legislator first. If they hear about 340B from a pharmaceutical company or a health insurer or pharmacy benefit manager, they don't hear what Mimar said and Jesse said. They hear that it's money going out the door. You know, it's either the health insurer blaming the manufacturers, or the manufacturers blaming the pharmacy benefit manager or the health insurer for who's the one that's making the program not work the way it's supposed to. But the issue is that when a legislator or congressional member hears from pharma first about this 340B program that's grown too much too fast, and we don't know what they do with the drugs, and we don't know what's happening here, and too many people are abusing the program, it's harder for someone like Mimar to then come in and try to tell them how the program actually works. So a lot of our advocacy is correcting bad information or misinformation that they have learned from other participants in the 340B program, but the other participants don't ever talk about the patient impact. And so there's always tension of having to correct this misinformation or trying to get to this legislator or congressional member first so they have the real impression on 340B and not us having to peel back the layers of misinformation, which is usually what happens, unfortunately, because manufacturers and pharma and PBMs have bigger lobbying power than us. And so that's why things like, what Age Unite is doing next week is so important, because we have to show up in large numbers to drown out their advocacy that's driven by a lot of money that is, also generated because they're not shipping to contract pharmacies. So pharmaceutical manufacturers are making a lot of revenue in this time that they are not providing drugs to contract pharmacies.
So real quick, and I think I answered this in a question, and I want to say, I'm trying to read the questions. I'm trying to answer questions on the chat and then listen also to what everybody's saying. But the thing is, we know that the revenue that is realized by FQHCs, I'm not talking about Ryan White here. I know this because this is the information we've been given, is only 6% of pharma's revenue. They're saying the money's going out the door. 6% to help all these people in the country? You gotta be kidding me. 6%.
Let me turn to California specifically, where there's confusion at the gubernatorial level on 340B and Medi-Cal, and it's chaos. And it's embarrassing. Can you share with the audience, those who are living in California or outside, what happened, what the governor did in California, and the financial impact it's having on covered entities, which is, my words, devastating?
Yeah, and so this is like part of why 340B has so many layers to it, that there's so many different challenges, and those challenges definitely can vary state by state. So as we're having this contract pharmacy issue with manufacturers, we also have the issue with pharmacy benefit managers and health insurers lowering our reimbursement because you're a 340B entity. Then there's another battle with your state, because there's an intersection between Medicaid and 340B, where if a prescription is claimed by Medicaid, we cannot get 340B savings on that prescription. That's under law and statute, and that's okay. However, also under the ACA, managed care, we were allowed to get 340B savings through managed care. And so that has helped a lot of health centers and 340B covered entities in general, and expanding their services and expanding 340B savings. However, states have their own separate issues with managed care and working with health insurers administering their Medicaid programs. So there's a state like California, and this also happened in New York, but they're actively fighting it. In California, the governor thought it would be much better for the state of California if we moved all of our managed care benefits, which included the pharmacy benefit for Medicaid beneficiaries, back into traditional Medicaid, which means they are kicking those health insurers out, which not saying is not for any good reasons of the state trying to control their costs. But the downside to that is now there's a whole population that covered entities are serving, but they are not able to get any 340B savings from serving those patients, because under the law, you cannot get a Medicaid rebate and a 340B discount on the same drug. And so as much as the health centers and all covered entities in California try to educate, the governor and the state to say, hey, you're moving this money from one place to another, but there's no guarantee that the revenue that the state makes from the rebates will get reinvested back into Medicaid patients or patient care in general. That money can go to roads, bridges, they could build anything they want to, because it goes back into the state's bank account. The difference is when it was under managed care, that money went back into health centers, and then that money got reinvested and passed down to patients. So now they're trying to negotiate with the state, but the issue is also with 340B is there's not just a one size fits all approach or dollar amount. It can vary. And so the state is like, well, maybe we'll give you one-time funding to help float you the next year, but then what are they supposed to do the year after that? And what does that mean? Are you supposed to fire people because you don't have, access to the 340B revenue? Are you supposed to stop serving dental patients and close down your dental department? What are these, health centers and other providers supposed to do in California? Because there is not actually a pot of money that measures up to 340B savings on the state level or the federal level. And we talk about creating federal solutions that cost the taxpayers money, because right now 340B is funded through manufacturers making millions on millions of dollars who say they care about patients, who say they care about the patients that use their medications. But when it comes down to it, they don't want them to have too much access. They don't want them to be able to get it from every provider, only the small pots that they can control. And so that's what we're seeing, is that there's different hands in the 340B honeypot, and everybody wants a piece of it, but the person who is impacted the most are the patients. And that's the moral of all the stories that we're telling today.
Yeah, and if I could just add on to that a little bit, one of the stories that I don't think gets shared enough, and it's on us as advocates to share it more, is the ability of 340B savings to generate and drive significant quality improvement programs and enhanced quality of care for the people we serve. Speaking just of the Ryan White funded clinics across the country and those that are participating in the 340B program, the clinical outcomes that we are having compared to folks who are not participating are significant. Here where I work, 95+% of the people we serve are achieving durable viral suppression or an undetectable viral load. So not only is that a great personal healthcare outcome for them, it's great for the system because healthy people cost the health industry less money. So it's saving Medicaid programs money, it's saving the insurers money. But then beyond that, it goes to people who are achieving durable viral suppression or an undetectable viral load are physiologically unable to transmit HIV to somebody else, something that is, we refer to as undetectable equals untransmittable. So it's the story here is going beyond just, what resources we're able to deliver and what programs are buoyed by 340B savings. It goes beyond that to really quantifiable savings for the health system. It goes to better patient outcomes and better patient care. And it goes to a public health goal that we all share, which is ending HIV as an epidemic and reducing the number of new transmissions. When you look at why folks are fighting in this space, and you look at what the outcomes are and what the deliverables of 340B are, and you start hearing from detractors of the program, my question is what are you trying to pull back from? What is it really that is, when you look at the outcomes of this program, what is it that you're opposed to? I don't understand what it could be. You're opposed to better outcomes? You're opposed to a more robust safety net? Or are you just really opposed to your role and responsibility as a part of society to contribute to the outcomes? Because at the end of the day, and this was delineated in a letter from a manufacturer to Congresswoman Barbara Lee's office just within the last 10 days or so, a pharmaceutical manufacturer basically saying, it is not our responsibility to help buoy the healthcare and social safety net. Our job is to make medicines and try and get those medicines to as many people as possible. Well, I tell you what, you're not going to get them to as many people as possible if you reduce the funding that's available to the doctor to pay for the doctors who are writing the scripts for the medications you're producing. It's a circular firing squad level of logic that you can hear the passion in all our voices. Because there's really only one answer that seems to make sense, and it's shareholders and profit margins, which are driving the conversation. It's really unfortunate because we're talking about the most marginalized, the most vulnerable people in our society. And I know look at the name of the folks who are here: Grantmakers in Health and Funders Concerned About AIDS. This is what you guys do. This is your raison d'etre. And we need your help and we need your support in making this case for the importance of this program, because without it, the investments y'all are making in my organization and others are not going to be delivering the outcomes that y'all are hoping for, because we know that it's going to take an all of society approach to getting to where we want to go.
Well, I know that we're coming to a close, Jeff, but as a board member of FCAA and a CEO of AIDS United, I really appreciate that this conversation has been put together, because the role that philanthropy plays And some of the largest donors for the HIV space have been some of these manufacturers. Harold Phillips from the White House tells us that the national HIV/AIDS strategy is not a federal strategy, it's a national strategy, and it requires both federal resources and private sector resources. And in the private sector, 340B is a major component. Should those resources be diminished, we want to just make sure that the philanthropic sector is aware that should they be diminished, we may need more help. And as we do the work of helping to preserve the 340B program, particularly in our messages with Congress and even our messages at state levels about Medicaid and other underfunded activities by state legislators, that work of advocacy is continually underfunded from the philanthropic sector. We need the philanthropic sector to be aware of both. Something may be coming with regard to 340B that could create a major problem for service delivery for the HIV community. But at the same time, we need the resources to make sure that our story and the impact is being heard.
So my point, and I also, well, I'll do that after. When Bill said the pharma said it's not their responsibility, they were given the responsibility in 1992, and we're just trying to hold them up to the law, what was passed by Congress. They don't want to do it now. Well, I'm sorry. That's the rules. That's the rules that we play by. I also want to thank every single one of you for listening to us today. I welcome the conversation. Thank you for all that you have done to help people living with HIVs. It does not go unnoticed. We are very, very, very thankful of what you do. Unfortunately, we just need more. I'm sorry, we just do. There's more people living with HIV today than there were 20 years ago, 30 years ago. So and people are living longer. Thank goodness. Thank goodness people are living longer, but their needs are more too.
Second. Furia?
Oh, I guess it's just closing remarks. Well, I really appreciate the time. Definitely NAC. I think as a national association, I love to do anything with an actual health center on the ground who could really paint the picture the right way. Really appreciate, this is a new space, I think, of thinking about how can we solve 340B, but I think we've all highlighted how the healthcare system in America, the fact that there's states that still don't have Medicaid expansion and how that impacts the patients that you serve. You're in a state that has not expanded Medicaid, you're dealing with a higher population of uninsured patients or underinsured patients. You could think you have insurance and it's actually junk insurance and only covers if you have a heart attack and not even medication. So the wide variety of patients who have different healthcare needs, but also the inability to have comprehensive health insurance really highlights the need for 340B. And we're, providing these services on a program that is being pulled out from under our feet. And so as we are brainstorming solutions, it's how can we also support this administration as they are trying to protect this program, and how do we take advantage of this opportunity under the Biden administration, because everything changes from administration to administration and from Congress, to Congress. And so how can we take advantage of the moment right now where we are actively litigating against manufacturers and their behavior, where the government is trying to exude all their authority, but they need Congress to step in. So any way that someone on this call, if you feel like there's an advocacy strategy that we have not pursued, I think I can speak for everybody on the call that we are all ears, as this is a new day in 340B. The Gilead restrictions, being the last manufacturer over the last 2 years to have restrictions against grantees, specifically health centers, Ryan White clinics, STD clinics, Title 10 clinics. That is really eye-opening to say that now manufacturers are changing their viewpoint from just only hospitals to say, well, we've been getting away with this for 2 years. Why don't we throw those health centers in there now? Why don't we throw these clinics in there too? And we could force their hand. And so watching that is just very scary.
We can't hear you, Jeffrey.
Yeah. I'm having technological challenges. Thank you for an inspirational discussion. Thank you to FCCCA and Grantmakers in Health for sponsoring this. But most importantly, thank you for the work that you do every day. As a philanthropic CEO, I spend endless hours trying to figure out how to solve problems. We've worked in the 340B space for 30 years, and we've made progress, and we've gone backwards in some cases as well. Bill raised an important issue. We have to tackle the PBM and the health insurer issue. If those issues aren't tackled and addressed appropriately and effectively, this problem will never get better. Thank you all for joining us, and it's been wonderful having you. Take care.
Thank you, Jeffrey, and all of you. I just want to thank Grantmakers in Health again for joining with us, and for all of you for watching, and to remind you that this will be was recorded, will be posted on our website. I know we didn't get to everyone's questions, but we will reach out to the participants with unanswered questions and share their responses with you. So thanks for your time and have a great day.